student. I'm going to be conducting the physiology practice questions class, I should say, along with Ahmad and Jandali second year. I'm going to do the first half and he's going to do the second half. So we'll start with questions from the first lectures, like mass balances and clearance and everything, and then we'll get all the way until tubular filtration and everything until he takes over. All right, let's begin. So a 45-year-old patient is being considered for initiation of a medication eliminated by the kidneys. Before prescribing it, the clinician first estimates the patient's GFR to determine whether the drug can be given safely and at what dose. After the drug is administered, the clinician measures its renal clearance to assess how efficiently the kidneys are eliminating it. Several marker substances are used to evaluate renal handling. Which of the following is used to estimate GFR? And you guys can put your answers in the chat or on mute, however you wish. Okay, anyone else want to answer? Okay, perfect. We'll move on to the next one and then we'll do the explanation. Which of the following substances is freely filtered and its secretion is greater than its reabsorption? Inulin, glucose, creatinine, or PAH? Okay, perfect. Now let's talk about it. First, clearance. What is clearance? So renal plasma flow is all the flow of plasma that comes into the kidney. Okay. So all of it is going to come in and can you guys see my cursor? 1 second.
Yep, we can.
Oh, perfect. Okay. Let me turn this off then. Okay. So all of it's going to flow into the glomerulus. 20% is going to be filtered in the glomerulus and 80% is going to continue in the peritubular capillaries. These red lines over here. So out of this 20% that's filtered, it's going to be cleared. The volume of the plasma is going to be cleared of a substance per unit of time. Okay, that's clearance. And we need to know that to calculate GFR. GFR is important because it tells us about kidney function. The substance that we use to calculate GFR is a substance that is cleared from the plasma completely in the glomerulus. It's not secreted later, it's not reabsorbed later, it's completely cleared over here. That substance is inulin. But inulin is impractical to use in real life. Let's see, is this on? Inulin is impractical to use in real life because we have to infuse it over a 24-hour period. So creatinine is better because it's endogenous, it's already in the body, and it's already made by the muscles continuously. So we use creatinine to estimate GFR or glomerular filtration rate, and the normal amount is 120. Another thing is because it's secreted by the muscles constantly, it's not good to do it right after exercise because the creatinine will be super high and you'll think this person's GFR is really low and they have a problem, but it's not actually that. Just measure it when people are at rest. Okay, now about PAH. PAH is used to measure renal plasma flow, and that's because out of the 20% that flows into here in the glomerulus, it's freely filtered, but the other 80% is also cleared of PAH. So all this 80% of PAH, all this 80% of plasma, all the PAH is going to be secreted into the tubule, and eventually all of it will end up in the urine. So basically, all the renal plasma flow is cleared of PAH. So we use PAH to estimate renal plasma flow. Okay, next question. We're going to utilize what we used here for the next question. And one more thing. The equation for clearance. This is a very, very important equation. I want you guys to memorize this. It's UV over P. It's very easy to remember. So basically, it's urine concentration multiplied by the urine volume divided by the plasma concentration. Okay, and we know that we use creatinine to measure GFR, and we use PAH to measure RPF. Next question. A 45-year-old patient is being considered for initiation of a medication that is primarily eliminated by the kidneys. Before prescribing the drug, the clinician first estimates the patient's GFR to determine whether the drug can be given safely and at what dose. After administration, the clinician measures its renal clearance to assess how effectively the kidneys are eliminating it. Several marker substances are used to evaluate renal handling. First, what is the renal clearance of this drug? Okay, good job. That was fast. Okay, so renal clearance, super easy, UV over P. So urine concentration is 100 multiplied by 1 divided by 2, 50 ml per minute. Now it's going to get a little bit harder. An initial set of laboratory tests obtained from a 42-year-old male patient to establish baseline renal function parameters. Given the table below, which of the following estimates the filtration fraction in this patient, assuming urine flow of 1 milliliter per minute? Y'all are fast. Crazy. Okay, any other answers? Can anyone drop the equation in the chat that we're going to use for this? Perfect. Okay, so filtration fraction is measured using glomerular filtration rate over renal plasma flow. We said that we can use inulin to measure glomerular filtration rate, and we can use PAH to measure renal plasma flow. So first we're going to calculate the clearance of inulin. It's going to be 100. Clearance of PAH is 500. And the ratio 100 over 500 is filtration fraction. So it's 20%. E is the correct answer. Okay. A patient has a kidney transport maximum of 180 for glucose, GFR of 100, plasma glucose level of 260 over 100, urine flow rate of 1.5. Why does glucoseuria occur in this patient? MashaAllah. Okay, let's talk about glucose. So you know how we said earlier, let's go back. We have these nifty little things from Shams's slides, Dr. Shams's slides. So we said inulin is totally cleared over here, right? It's not passing between the peritubular capillaries and the tubules. It's totally cleared. PAH is secreted. Glucose is a little bit different. Glucose is completely reabsorbed, or it should be completely reabsorbed in any normal person. The only reason it would be excreted is if we reach the filtration maximum, as in we filtered all of it, we reabsorbed all of it, all the transporters are full, and we still have more glucose. Only in that case will we excrete it. So this is called Tmax, or the maximum amount we can reabsorb. If the filtered load is more than Tmax, that means some of it is being excreted. Okay, so what would be the approximate rate of this glucose excretion, assuming normal kidney functioning? Okay. By the way, guys, normal kidney functioning doesn't mean that they don't have too much glucose. They could have too much glucose. Like it could exceed Tmax. Okay. Okay. So the way we're going to calculate the excreted amount is the filtered amount plus secreted minus reabsorbed. This is just a general equation you can use for anything. Over here, we know glucose should be totally reabsorbed. It's not secreted, so we can take this off. So the excreted amount equals the filtered minus the reabsorbed. Now, how do we calculate the filtered amount? There's an equation, filtered load. How do you calculate filtered load? Perfect. GFR multiplied by plasma concentration of a substance equals filtered load. So over here, we're going to have to do a little bit of converting, and I wouldn't have included this if it wasn't included in PATH. You sometimes do need to do it, but it's very easy. 260 over 100 is 2.6. So 2.6 multiplied by 100, which is the GFR, is going to give you the filtered load of glucose, 260. Now to calculate the excreted amount, we need to do filtered load minus reabsorbed. And over here, we're given the maximum reabsorption. Maximum reabsorption is 180. So 260 minus 180, the correct answer is 80A. Do you guys understand? I can go over it again. Okay, perfect. All right. Now, for the following values, the free water is what? Calculator. You have plasma osmolarity, urine osmolarity, and urine flow. Awesome. Okay, let's talk about free water. First of all, what is it? So osmolar clearance is the volume of water needed to excrete all the solutes in the urine at plasma osmolarity. So it's like the solute water. We need this amount of water to dissolve the solutes. Any water beyond that is called free water. So if clearance of water is over 0, we're obviously losing a lot of water. We have dilute urine. If clearance of water is less than 0, then we're only using the amount we need to use. So it's very little urine. That's all you guys need to know. These are the equations to calculate it. So clearance of water, osmolar clearance is the same as clearance of anything. Urine concentration multiplied by urine volume divided by plasma osmolarity. And then to get the free water clearance, again, it's the total urine volume minus this solute water, minus the amount we need just to dissolve the solutes. That's going to give us the extra water. Go back to the equation. So basically, serum osmolarity is 150 over 4. So 150 times 4. So urine osmolarity times urine flow divided by plasma osmolarity, that's going to give you 3. Now, the volume of urine minus the osmolarity, it's 4 minus 3, so the answer is 1. And this was just like one slide or 2 slides in your lecture, so I didn't want to include it, but it did show up in past a couple times, so I'd recommend learning this. Okay, moving on, next lecture. What is the effective charge on particles between 18 and 42 angstrom in size on glomerular filtration? A, positively charged particles are filtered easily and negative are filtered with difficulty. B, negative are filtered easily, positive are filtered with difficulty. C, charge has no effect, only size matters. Or D, both positive and negative are filtered equally. Correct. Okay, so let's talk about this. Filtration. If it's 0 to 18, you're good, pretty much. If it's 18 to 42, it depends on size and charge. Over here, you guys can see that the most filtered is polycationic gestrin. Cationic means positive, anionic means negative. So cationic means positive, so positive is filtered more. 42 plus, no chance, it's not going to be filtered. Does anyone know why between 18 and 42, the positively charged ones are filtered more? So between 18 and 42A, why are positively filtered more? Okay. Repelled by a negative basement membrane. Close. Attracted. Perfect. Okay. So, oh yeah. So negatively charged things would be repelled by the negatively charged basement membrane slits. Positively charged would be attracted to it. So that's why they're filtered easily. Now for 0 to 18, they may have trouble because they may bind to negatively charged plasma proteins. So over here, it's actually reversed. Over here, negatively charged would have less trouble. And positively charged will have more trouble because it might bind to negatively charged plasma protein. So 0 to 18, which one is easier to filter, positive or negative? Negative, good job. 18 to 42, positive is easier to filter. And 42 plus, not going to be filtered. Okay. Which combination of plasma colloid osmotic pressure, afferent arterial resistance, and Bowman's hydrostatic pressure will yield the lowest glomerular filtration rate? Okay. A, high plasma colloid osmotic pressure, high afferent arterial resistance, and high Bowman's hydrostatic pressure. B, low plasma colloid osmotic pressure, high afferent arterial resistance, and low Bowman's hydrostatic pressure. B, high plasma colloid osmotic pressure, high afferent arterial resistance, low Bowman's hydrostatic pressure. Or D, low plasma colloid osmotic pressure, low afferent arterial resistance, and high Bowman's hydrostatic pressure. Wow, everyone got it right, mashallah. Okay, let's explain it. Oh, okay, the picture's not showing up, but basically, P is hydrostatic pressure and spatially pushing. We're pushing out of the capillary. C is colloid pressure and it's sucking, or pi, sucking. It's sucking into the capillary. When hydrostatic pressure is high, we're pushing things out of the capillary. So glomerular filtration rate would go up. When capillary oncotic pressure is high, we're sucking things into the capillary. So filtration will go down. When renal plasma flow is high, a bunch of things are flowing into the capillary really fast. And if it's flowing super fast, the colloid osmotic pressure goes down because the proteins can't suck in a bunch of stuff. They just don't have time because the flow of plasma is so fast. So when renal plasma flow goes up, oncotic pressure goes down, GFR goes up. So repeat one more time. When hydrostatic pressure goes up, GFR goes up. Oncotic pressure goes up, GFR goes down. Plasma flow goes up, GFR goes up. And the answer to that question is A. High plasma colloid osmotic pressure, high afferent arterial resistance, and high Bowman's hydrostatic pressure. And this is because high plasma colloid osmotic pressure will lead to a lot of sucking in, so lowers GFR. High afferent arterial resistance, we'll get to that, and high Bowman's hydrostatic pressure. One more thing, Bowman's hydrostatic pressure is the amount, hydrostatic, again, we said it's pushing. So the Bowman space is the outside. If we're pushing things into the capillary, low GFR. So this will lead to low GFR. And why does high afferent arterial resistance lead to low GFR? Can anyone answer in the chat? Okay. Okay, let's go over it. So basically, imagine it like this. This is your normal capillary. If you pinch this area right here, if you pinch this area right here, plasma flow inside is going to go way down. You're constricting it. It's like constricting a pipe, basically. You're going to have less flow. And like I said before, when renal plasma flow goes up, GFR goes up. So when renal plasma flow goes down, GFR goes down. So if we constrict the afferent arteriole, renal plasma flow goes down, and thus GFR goes down. But efferent is a little bit different. In efferents, does the renal plasma flow go up or down? And does GFR go up or down? Okay, correct. There will be reduced renal plasma flow, but because there's such a buildup of fluid over here, there's going to be a buildup of hydrostatic pressure pushing outside, pushing all the things in the capillary outside. So we're going to have higher GFR at first. And then it just depends which thing dominates. So at the beginning, we'll have higher GFR because it's pushing all the stuff out. And afterwards, renal plasma flow will dominate. And because it's so low, GFR will go down. So renal plasma flow decreases, but GFR increases. So using the attached table, constriction of only efferent arterioles will have which effects on renal plasma flow and glomerular capillary hydrostatic pressure? Correct. Renal plasma flow will decrease, but hydrostatic pressure will increase. Okay, let's talk about it one more time. Okay, can you guys tell me what table this is for? GFR increases, but then it decreases because the RPF dominates. Constriction of which arteriole, afferent or efferent? Efferent, correct. So at first, glomerular filtration rate will increase, and then it'll decrease because renal plasma flow will decrease so much that it just goes down. Over here, constriction of afferent arteriole, GFR decreases just no matter what. There's no amount of increase. Okay, another thing, factors affecting GFR. So basically, if we have congestion of urine in the urinary system, like we have a kidney stone or glomerulonephritis or something, there's going to be increased Bowman space pressure, and that's going to decrease GFR. Another thing, if we have dehydration, we have increased colloid osmotic pressure because there's a higher concentration of proteins sucking in, so that's going to decrease GFR. When we're hungry, we use a lot of plasma proteins, or starving people use a lot of plasma proteins. So that's going to increase GFR because it's less colloid oncotic pressure. Okay. And in the end, just one recap. RPF goes down, GFR goes down. RPF goes up, GFR goes up. Okay. Which of the following will most likely stimulate the autoregulatory tubuloglomerular feedback system in the kidney? A, increase in sympathetic stimulation of afferent arteriole. B, decrease in GFR. A, decrease in glomerular capillary pressure. D, increase in sodium delivery to the macula densa. Or E, decrease in arterial blood pressure. Okay, any other answers? Correct. Okay, let's go over it. Autoregulation of blood flow. So this is the immediate thing that happens. This is like automatic. There's also humoral and neural regulation of blood flow, and it comes from the brain, it comes from hormones and stuff like that. But that's going to be gone over later. Over here, let's go over autoregulation. This is immediate. So first is the myogenic mechanism, and this is just when muscle stretches, it releases calcium, and that's going to lead to vasoconstriction of the afferent arteriole, and it'll decrease blood pressure. Then there's tubuloglomerular feedback, and that's one we were just talking about. Increased sodium chloride to the macula densa, this increase sodium chloride to the macula densa, which will increase the action of this pump, sodium potassium 2 chloride. That's going to increase ATP, it's going to increase adenosine, and in the end, increase calcium. So both of these increase calcium and lead to vasoconstriction of the afferent arteriole. Okay. In normal kidney function, at the end of which of the following nephron segments would you expect the tubular fluid to have the same osmolality as plasma? Good job. Okay, let's talk about it. Okay, where do glucose, lactate, and bicarbonate get reabsorbed the most? Good job. One more. Tubular fluid is diluted in the ascending loop of Henle, especially in the thick segment. Which of the following explains that? Excellent. Okay, let's talk about it. This is a really, really great image. I'd recommend using it to study all of this stuff. So first of all, in the proximal tubule, we're absorbing a bunch of stuff, especially sodium. Sodium is absorbed with glucose, it's absorbed with water, and it's absorbed with bicarb, and then water moves passively. And because we're absorbing all these solutes and water at the same rate, it stays the same concentration as the outside fluid. So this isn't the concentrating segment, it's not the diluting segment. Things stay the same here. We're just absorbing a bunch of stuff. Now, at the descending limb, we call this the concentrating segment because it's permeable to water. So water is being reabsorbed in such huge amounts that this becomes very concentrated. Then we go to the ascending limb and we call it the diluting segment. And it's called the diluting segment, even though it's impermeable to water, it's because sodium, potassium, chloride, all of that is being absorbed. And so we're left with urine that's deplete of all of these solutes. So it's pretty watery, it's dilute. Later distal convoluted tubule and the collecting duct, these are the areas of fine tuning. Okay. So this is where the hormones act, antidiuretic hormone, aldosterone, that kind of stuff. It all acts over here. So again, over here is absorption of a ton of stuff, and it's all going to be isoosmotic. Over here is a concentrating segment. Descending limb is a concentrating segment. Ascending limb is that diluting segment. And distal convoluted tubule is our salt and stuff like that. And over here, collecting duct is fine tuning. Let's go back and let me just say the correct answers, please. Okay. So this was proximal tubule, have the same osmolality as plasma. Glucose, lactate, and bicarb all get reabsorbed in proximal tubule again. And this is correct. This segment does not allow water to be reabsorbed, which dilutes its solute content. This area over here does not allow water to be reabsorbed. And so then we're going to reabsorb all these solutes and we're going to be left with dilute urine. Okay. A patient with uncontrolled hypertension is placed on a new diuretic targeted to the sodium reabsorption site in the basolateral surface of the renal epithelial cell. Which transport process is a new drug affecting? Facilitate diffusion, solvent drag, sodium hydrogen exchange, sodium glucose co-transport, or sodium potassium ATPase pump. Correct. The answer is E, sodium potassium ATPase pump. So back to this picture, but now we're going to go in more detail. So at the proximal tubule, again, we're absorbing a bunch of stuff. We're actively absorbing sodium with glucose, with bicarb. There's a sodium hydrogen exchanger, but sodium is actively moving over here. Water is just going to follow. And because we're absorbing all of this sodium, it leaves a gradient for chloride to be reabsorbed more in the second half of the proximal tubule. Okay, so chloride will be absorbed by this thing called solvent drag. So that was one of the options here. Over here, solvent drag. Solvent drag is how we absorb chloride in the second half of the proximal tubule. Okay, next, descending limb, we said it's the concentrating segment. Okay, over here, ascending limb. This is a very important transport you need to know for the ascending limb. It's sodium, potassium, 2 chloride. Okay, no water is reabsorbed here, but all of this is reabsorbed. And because sodium and potassium and chloride are being reabsorbed, it creates a gradient for calcium and magnesium to be reabsorbed paracellularly. And this is voltage-driven reabsorption. So over here, we have sodium being reabsorbed actively, chloride by solvent drag, and calcium paracellularly. And over here, we have sodium, potassium, and chloride all being absorbed, and calcium and magnesium paracellularly by this voltage-driven gradient. Okay. Then later on over here, this is aldosterone dependent. We have sodium absorption and potassium excretion. And then we have antidiuretic hormone dependent water reabsorption. One more thing, all of this is over like apical membrane, all of this is absorption, everything. But to get the sodium and potassium, to get everything out of the blood, out of the interstitium or out of the cell and into the blood, we always use sodium potassium ATPase. That is the basolateral transporter that's going to be the most important. So whenever in this question it was saying, how do we do sodium reabsorption in the basolateral surface or whatever, it's always going to be sodium potassium ATPase. Sodium hydrogen exchange is where we mentioned it. Which part of the nephron? Proximal tubule, perfect. Solvent drag is where? Proximal tubule again. And sodium glucose co-transport is also proximal tubule. Facilitate diffusions everywhere. Okay. Again, I really recommend going over this and like covering it and then just drawing all the things that you need to remember. It's really good for remembering. Okay. In a person on a high potassium diet, which cell in which part of the nephron will be expected to secrete the most potassium? We're trying to get rid of potassium. So apical cells in ascending loop of Henle, principal cells in ascending loop of Henle, intercalated cells in early distal tubule, intercalated cells in distal collecting tubule and collecting tubules, or principal cells in late distal convoluted tubule and collecting tubules. is principal cells in the late distal convoluted tubule and collecting tubules. So let's talk about aldosterone. This is super duper important. There were a bunch of questions on this. It's secreted from the principal cells of the distal convoluted tubule. Sodium, we're going to absorb it. Potassium, we kick it out. So over here, this is with normal potassium intake. Most of it is reabsorbed in the proximal tubule, a little bit here, a little bit there, and a little bit is excreted. But if we have so much potassium intake, like in this question, we're going to excrete a ton of it. And we're going to do that through aldosterone. Aldosterone is secreted from the principal cells, and it's going to kick potassium out and absorb sodium. So again, aldosterone increases the expression activity of sodium channels on the apical membrane. It increases the amounts of sodium, potassium, ATP is in the basolateral membrane, and this enhances the reabsorption of sodium and the secretion of potassium. Okay, a little bit more about aldosterone. So, 1 second. Okay, yeah, so this is just a fun fact. It was on your slides. I don't know why it's so important, but basically we have cortisol in our body, and it's a glucocorticoid. And then we have aldosterone, that's a mineralocorticoid. And sometimes the body gets mixed up between them. Normally we have normal amounts of cortisol and aldosterone. But if we eat like a ton of licorice, it blocks 11 beta HSD2, which is what breaks down cortisol. So now we have too much cortisol. And the body gets mixed up with cortisol and aldosterone, and it uses the cortisol to activate the mineralocorticoid receptor, and this leads to apparent mineralocorticoid excess. Or it looks like mineralocorticoid excess. It looks like hyperaldosteronism. So what does hyperaldosteronism look like? So first we have sodium retention, which leads to hypertension, hypervolemia, and edema. Then we have hypokalemia, which leads to muscle weakness and constipation and changes in the heart rhythm, which is very serious. And then we can have alkalosis, which leads to tetany and cramp. So this is just a bonus question. Which condition below will result when there is decrease in secretion of the hormone aldosterone? Hypernatremia, alkalosis, hyperosmolality, hypokalemia, or hyponatremia? Good job. Yes, it's hyponatremia. Why? If we don't have enough aldosterone, we're not bringing sodium in and kicking potassium out. So we're losing sodium and we're keeping potassium. So we'd have hyponatremia. Okay. Now, a little bit more about potassium. Potassium is very, very tightly regulated in the body. If it goes a little bit too high and we have hyperkalemia, that can be a very big problem. And if we have hypokalemia, again, it can be a big problem. Signs of hypokalemia include vomiting and diarrhea and alkalosis. Can anyone tell me why there would be alkalosis and hypokalemia? It's a bit complicated. Okay. It's because whenever we have, oh, good. Okay, yeah. So whenever we have hypokalemia, we want more potassium in the plasma or in the serum because the potassium is so low. So to get the potassium into the serum, we're going to absorb hydrogen, and hydrogen is going to go into the cells. If hydrogen is high in the cells but low in the plasma, then we're going to have alkalosis. We have the reverse over here in hyperkalemia. Okay, we're going to have acidosis. And that's because the hydrogen is going to be super high in the plasma because we want to absorb potassium and put it in the cells. Potassium is too high in the serum, so we want it to be in the cells. And to do that, we get rid of hydrogen, we put it in the serum. So that leads to acidosis. So in hyperkalemia, we have acidosis. Hypokalemia, we have diarrhea, vomiting, and alkalosis. Okay, now let's talk about regulation of calcium. I think this is one of our last slides. So calcium, all you need to know basically, parathyroid hormone increases reabsorption of calcium, and calcitriol increases reabsorption of calcium. Calcitonin gets rid of calcium. Other things that increase the absorption of calcium would be alkalosis, increased plasma phosphate. That's because if we have high phosphate, we're going to have high PTH because PTH is also known as phosphate trashing hormone to get rid of the phosphate. So if we have high phosphate and then high PTH, we're going to have more reabsorption of calcium. Last thing is extracellular fluid reduction will increase calcium reabsorption, and extracellular volume enlargements will reduce calcium reabsorption. I think that's it. Yep, that's all for my part. Thank you guys so much. I think that Ahmed will continue.
Thank you very much, Hajar. Great. Beautiful. I was listening, and I really wish I could take the final exam right now with them. You caught everything that's high yield in such a convenient way for us. Thank you very much. And I'll take the microphone from here. Let me introduce myself. I'm Ahmed Al-Jandali. I'm in my second year right now. Uh, First of all, let me say I really wish you all do. best. Wow. Um,
Renal
Renal
block
block
is
is
just
just squeeze, you know. It's squeezed within a lot of exams. But you guys got it. It's a very small one, and inshallah, it's gonna be very easy for everyone. Okay. So without further ado, just allow me to um, share my screen and start with my portion of the questions. Okay. So first of all, I would just like to note that a lot of these questions that me and Hajar have compiled for you guys are strongly inferred from past papers and past finals. We've seen how our batches got treated in the finals, and we tried to recreate what we saw in our exams. Um, and it also means that these questions have a higher chance of reappearing, hopefully, but also in a conclusive way, hopefully in covering the high yield topics that you need to know. For my part, we're gonna be discussing P7 to P13. I've divided them across different categories, and the first the first pile of questions we have is gonna target ADH and osmolality. Okay, so um, the first question we have is a case. It's a multi-question case uh, that we have a 27-year-old man presenting to the emergency department after spending an entire day without access to water while working outside. He reports intense thirst and low urine output. After we did laboratory results, we found that the plasma osmolarity was increased, the serum sodium was 125, urine osmolarity was around 1,500 milliosmoles, blood pressure was reduced, and the renal function was normal. So, what do you guys think? Which is the following changes that are taking place in our patient? Is it decreased osmoreceptor activity, increased, or decreased ADH, or increased ADH? Any other guesses? Okay. Perfect. That is correct. Whoever said it's B is correct because it's increased ADH and increased osmoreceptors. And so basically the story here is that uh, we have dehydration, which means that our plasma is high in osmolality. Okay, it's not diluted as much. And that just triggers our hypothalamic osmoreceptors in our brain, and that tells our posterior pituitary gland to secrete ADH. ADH is secreted by posterior pituitary glands that are triggered by plasma osmolality. Okay? I hope that is clear. So for the same case, we have a different question now. So, what best describes the primary renal action of ADH hormone in this patient? So, basically, what does ADH do? Does it increase water reabsorption in the collecting ducts, increase water and sodium reabsorption? Does it increase TPR, or does it increase sodium reabsorption alone? You guys are acing it. It is true. It is B. ADH increases water reabsorption in the collecting ducts. Uh, how is that accomplished? Because ADH goes and inserts more aquaporin 2 channels in principal cells in the collecting ducts and other areas of our nephron. Okay, and basically that just allows more water permeability and helps our nephron reabsorb more water from our luminal space. Okay. Um, Meaning there's concentrated urine because we reabsorbed a lot of the water and helps our plasma get diluted. Okay, because we're taking the we're taking the water from our tubules and putting it back in our blood. That means a less diluted blood, a more concentrated urine, and a more diluted plasma. Okay. Now, whoever thought that ADH increases sodium reabsorption, you have to make sure you don't make that mistake again, because I've personally always mixed them both up. Remember, the aldosterone is the one that works with sodium and water. Okay. ADH only works with aquaporin 2 channels, and so therefore only water. And that is why um, choice C or A are wrong, because we are not dealing with sodium at all. And I hope that's clear. By the way, guys, I'm sorry I didn't mention this earlier. Whenever anybody has any questions, you can feel free to interrupt me, and we'll address your concerns. Okay. So for the third question of our case, so we know that this patient has high ADH levels, but which part of our nephron remains the least permeable to water, even with the high ADH levels? What do you guys think? Correct. You guys are so good. I think that was discussed with Hajar as well. It is indeed D. It is the thick ascending limb of Henle. It is always impermeable to water, and that's why we call it the diluting segment. Because as Hajar said, it reabsorbs sodium, potassium, and chloride and other ions, but it does not reabsorb water. And that's how our urine becomes diluted. So again, the thick ascending limb of Henle is the least permeable to water. Okay, for our final question for this case. So we observed that the urine osmolarity is extremely high, which is 1,500, extremely, while his serum sodium concentration was around 125. Um, so what is the following best explanations for what we found? You guys can read them. I think we've already like answered this in the explanation of previous questions. Any other guesses? Okay, that is true. It is B. As we just discussed, ADH increases water reabsorption alone. It does not play with sodium at all. Okay, so if we're taking water out of our urine and putting it back into the plasma, what is the result? We're not playing with any ions, no salts, nothing. Just the water, taking it from one place and putting it back in one place. If we're taking the water from our urine, which is in the case of ADH, increasing the reabsorption of water, back to our plasma, we will expect to find a very high osmolarity in the urine, because the urine still has the same ions but way less water, and our plasma has now more water, and that is why the serum sodium concentration is reduced. Okay? Is that clear? Lin, you are right to assume that for option D, it says that it leads to sodium dilution and hyponatremia, but it doesn't really mess with the sodium balance or aldosterone. Neither does it with aldosterone secretion. ADH is independent of these, but it's true that it causes dilution and hyponatremia because there is more water. Okay. Uh, For our second pile of questions, they're going to target renin, angiotensin, aldosterone system. For my aldosterone fans, here's where you shine. Okay, again, we have another case. So we have a 35-year-old man who came to the emergency department. He had acute blood loss that followed a motor vehicle accident. The blood pressure was low and he was tachycardic. But within minutes, the compensatory mechanisms are activated to preserve renal perfusion and extracellular fluid volume. So, my question for you guys is, which renal cell type is directly responsible for initiating the hormonal response that regulates blood pressure in this patient? Which cell is responsible for this hormone? Perfect, you are completely right. It is the juxtaglomerular cells of the afferent arteriole. They are our modified smooth muscles that sense the difference in blood pressure. These are our sensors. If there's an issue with blood pressure, not much blood is reaching the afferent arteriole, then we secrete renin. Okay? And I think I've spoiled the answer for this question. Juxtaglomerular cells do release which one of the following? It's true. It's renin, but please do not confuse them. You don't say angiotensin, angiotensin two, aldosterone, even though they're all part of the same system. Okay, renin is the one that starts with it. It's the one that triggers this whole cascade of renin, angiotensin conversion, everything. Okay. For our next question, so what is the most immediate stimulus for hormone release in this patient's condition? The one that's the fastest acting. Wow, yeah, you are very right. It is sympathetic nervous system activation. Again, remember that nervous system is the fastest acting or the most immediate trigger for this hormone release. Because in acute blood loss, there are bar receptors that are different from the ones that we just talked about that increase the sympathetic tone. And when this sympathetic tone is increased, there we do have beta 1 receptors on the granular cells. And what's the response of this stimulation is that these cells start releasing renin. Okay? It is faster than the macula densa pathway because, again, it's the nervous system. Just memorize it, and I hope it's clear that the nervous system is the fastest acting. Okay? Okay. Fourth question for this case is so this hormone that initiates the RAS system. So, what is the primary goal of activating this system in this patient? Why are we doing all that? Is it to increase renal plasma flow and promote natriuresis, or reduce sodium and water reabsorption, or do we want to restore blood pressure and extracellular fluid volume, or do we want to suppress antidiuretic hormone secretion? Perfect. You guys are doing amazing, mashallah. It is to restore blood pressure and extracellular fluid volume by the various effects of aldosterone and angiotensin 2, including fluid retention, sodium reabsorption. For angiotensin 2, it's um, endothelium constriction and etc. Okay. Okay. Uh, Next up, we have a question. What will happen to the levels of aldosterone, brain natriuretic peptide, antidiuretic hormone for someone who has hypovolemia? This one came in the previous questions. Okay, you guys are right. It is A. Aldosterone and ADH are going to be increased because we do have hypovolemia, and I think that's very much is that established. Why is BMP not elevated? Um, brain natriuretic peptide is something that is released when the atria of the heart are stretched. Okay. When the atria are stretched, they release this peptide. So normally we think the atria are stretched, we have high blood pressure or high blood flow, etc., right? And so the brain natriuretic peptide acts to decrease blood pressure. Okay? And that is why it's suppressed right here, because actually the opposite is happening. We have hypovolemia, so the atria are not quite stretched. We would expect low blood pressure. I hope that is clear. Okay. Okay. One more question. A patient is found to have an aldosterone secreting adrenal tumor. Which nephron segment exactly is affected, and which combination of changes is most likely seen? Is it the proximal tubule with ECF contraction, hyperkalemia, and acidosis, or loop of Henle, ECF expansion, hyperkalemia, and alkalosis, distal tubule, ECF expansion, hypokalemia, and alkalosis, or collecting duct, ECF contraction, hypokalemia, and acidosis? Okay, Ahmed, hypovolemia is basically when we have shrinkage in the volume of the blood, basically. Okay. It's just caused by an array of different conditions or situations. Okay. But hypovolemia is like an umbrella term for all of these situations, is when we have low volume of blood in our body. And generally, hypovolemia is directly related to low blood pressure. It has some other manifestations, but in our context right here, all you need to know that hypovolemia, because we have low volume of blood, naturally we will have low blood pressure. Okay? If you had a lot of water in a balloon, there would be so much pressure in the balloon. Okay? Okay, back to this question. We have an aldosterone secreting tumor. Um, okay. We have some guesses. Okay. You guys are pretty much very right. It is C. Okay. It is the distal tubule. It acts to expand extracellular fluid. It causes hypokalemia and alkalosis, as Hajar discussed. Let's kind of explore how that happens. Okay, aldosterone acts on principal and intercalated cells. You guys have to know that. This is the site of action of aldosterone. Aldosterone causes more sodium reabsorption. Here is where aldosterone plays a role in sodium reabsorption, and that causes subsequently, uh, in osmotic law, more water reabsorption. Okay, I hope that is clear because when we have sodium reabsorption, water follows. Okay. And that's how the extracellular fluid is um, kind of expanded. Okay. Uh, that's number one. So, how does hypokalemia and alkalosis happen? We know hypokalemia is when we have very low potassium. Aldosterone actually, um, aldosterone actually triggers a very important channel, and this is what I'll tell you. You guys know it. I'm pretty sure you do. Okay. And it's going to be the sodium potassium pump. hmm You guys know this, okay? Sodium potassium pump. Okay. It basically, okay, let's say here's the urine and here's the blood. Okay. This is a very simplified one. Okay. And here is our kidney cell. We have a channel here that is taking the sodium out. Okay. and the potassium in. Okay? So the sodium out, we need somewhere to put sodium here, right? Which is going to be a sodium channel taking the sodium from the urine back into the cell and then through this channel. So what acts on this channel is aldosterone. And this is not the only mechanism of action of aldosterone, but this is just one way to like engrave it in your mind is sodium potassium pump, okay? And so all of this potassium that is coming here, potassium, 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 where does it go? Does it just stay in the cell? No, the cell dumps it outside through other channels. Okay, I can't recall what the channels are called, but I just personally think maybe they're not significant here in this context. Um, but it's worth it. It's worth a check. Okay. And that's basically how we lose potassium and reabsorbed sodium. But what causes alkalosis? Again, um, it's good just like for a simple recall. Aldosterone also triggers another channel that secretes um, secretes potassium and hydrogen. And that's why we get alkalosis in the blood. Okay, aldosterone secretes these. Aldosterone also reabsorbs sodium, so it's very nice to just lay it out in your mind. Aldosterone reabsorbs sodium, secretes potassium and hydrogen. Okay, perfect. Okay, so for our third category today is going to be pH levels and buffers. Okay, this is a very nice question. I really enjoyed preparing this one because it took me personally a lot of research. So numerous buffer systems are participating in buffering H plus during acid-base disturbances in the body. Okay, we all know that. So there is a certain system that we have that has a pK value. Okay, so pK values of 5 buffer systems that are listed here in the table. So which one of these listed systems is the lowest buffering capacity? And remember that our target is pH 6.1. Perfect. You guys are pretty smart. Perfect. It is 5. It is number 5. And generally, if you just looked at the question, you'd see, oh, 5 is the farthest one from 6.1. And that kind of tells you the hint here. Bottom line of this question is that the pK that is farthest away from our target pH is going to be the least effective. And let's just have a very simple recap here, okay? We know that this is the rule or the formula we have to use to calculate pH levels. Okay, so in a certain situation where we have equal bases to equal acids, and that's the optimal situation, that's the best situation we can have. Equal bases to equal acids. Okay, let's say we have 50 up and 50 down, right? And that tells us it's log of 1. What is a log of 1? Is 0. And in that case that we have equal bases to equal acids, our pKa and pH are going to be equal because all of this is going to be 0 when bases and acids are equivalent. Okay, I hope that is established. And that tells us that the buffer, okay, on a different note, we have to understand that the buffer capacity, how do we assess a buffer capacity or the efficacy of it? It depends on 2 factors. It's the pH, pK difference, and the total concentration of this certain buffer. Okay, but in the question here, we said that all of them have equal concentrations. So The only factor affecting our situation here is the pH minus pK. And when is it the lowest? You guessed it. It's when pH equals pK. It's zero. The difference is literally zero. Okay? And that is when we have the optimum and the best situation and the best um, efficiency of a buffer system. Okay? When the pH pK difference is zero. And that is why when they asked us for the lowest capacity, we chose 6.8 because it's the highest difference. Okay? I hope that is clear. Are there any questions? Okay, I assume none. Okay, a very simple recall question here. Which of the following is the primary buffering system within erythrocytes? Perfect. Okay, correct. You all are correct. It is the carbon dioxide bicarbonate system. Okay. I put this last choice here to kind of trick you guys. It is true that the hemoglobin, hydrogen is a buffering system within erythrocytes, but it's not the primary. It's not the one that clears up most of the acidity in the blood. Okay. Okay. So a 52-year-old male presents with nausea after repeated vomiting. Shortly after, his breathing becomes slow and shallow. Arterial blood gas analysis shows an elevated pH. Okay, we have an elevated pH. Which of the following best describes his acid base disorder and the expected respiratory response? Okay, perfect, perfect. This is great. You guys have caught on. I just not like to note that there are so many clues inside the discussion, and that was done on purpose because I wanted to show you a question that you're not going to get on the exam because they're not going to ask you this clearly. They literally told you elevated pH, respiratory response. Okay, there are so many clues here, but it was just to make sure that you guys have a baseline idea of it. And let's just quickly describe how these questions are because 100%, you're going to get a question from this type of concept. Okay. First thing we need to assess is that we have this curve, which is bicarbonates against the pH level. Okay. For that, we have three concentrations of uh, CO2, CO2, CO2. What is the normal point here? The end point here, where we have 7.4 and we have 24 concentration of bicarbonates and 40. We all know these normal values. You have to memorize them. It's like your name. Okay? Okay. Now I will ask you, I want someone to reply to me. If we have the same carbon dioxide, but increased, we're on the same curve, okay? But increased pH, or no, this one, okay? Increased pH on this point. What do we have? We have an increase in bicarbonates. What does that denote? Perfect. Metabolic alkalosis. Why is it metabolic? Because it's bicarbonate that changed, not CO2. If CO2 changed, it's respiratory. If bicarbonate changed, it's metabolic. Now, alkalosis, because obviously the pH increased. Okay. So usually when we're here on this line, it's always metabolic, and when we're here on this line, it's respiratory, respiratory. And that's denoted if you look at the very nice graph here. Okay, so this line is the normal line. Again, the two ends of it are metabolic because we're still on the normal CO2 values. Okay, normal CO2 values. But the pH is increasing and decreasing. Why? Because of the bicarbonates. Okay. Um, Remember that CO2 is like the acid and bicarbonate is like the base, okay? Just memorize this analogy. It's not scientifically accurate, just memorize it like that and it will make your life way more easier. For respiratory acidosis, the CO2 values are changing, and so are the pH. Okay? How? Let's discover. Remember this word very much because it helped us so much last year in our exam because Dr. Angelica taught it to us. Okay? It's called Rome. It basically says that when you have respiratory any condition, you have an opposite trend. How does that mean? Okay, if we have respiratory acidosis, what does acidosis mean? Low pH. Okay, low pH means, according to Rome, it's decreased pH, increased CO2. You see how they're opposite? pH and CO2? Pretty much very opposite. pH decreased means it's acidosis, and because it's respiratory, we remember from Rome that the the thing here is going to be increased because it's opposite. Same as in alkalosis. Alkalosis here increased pH, but because it's respiratory, then it's going to be opposite. So what happened to the carbon dioxide? It decreased. Type. Don't worry about these for now. Rome also tells us that if it was a metabolic disturbance, it will go in the equal direction. So, meaning that if it was metabolic, if it was at acidosis, that means pH went down. But because it's metabolic, we know that the driving force for metabolic, as we said, respiratory for CO2, metabolic for bicarbonate. So metabolic acidosis, decreased pH, Rome meaning equal direction, bicarbonate goes going down in the same direction as pH. Last example we have is metabolic alkalosis. In alkalosis, we have an increased pH. And because it's metabolic, the driving force is going to go in the same direction as the pH, which is bicarbonate. Metabolic, bicarbonate, Rome tells us it's going to go the same direction. You see how? Okay. Why are these values here like this? It's because it's compensatory mechanisms, okay? It's basically meaning that if we have increased carbon dioxide, um, if you have increased carbon dioxide, it means that we have acidosis. And how do you combat acidosis? By um, by increasing the base. If you have a lot of acids, you increase the base to neutralize that. You see, if we have increased CO2, we need to increase bicarbonate to compensate for it. Again, if we have decreased CO2, we need to have lower bicarbonate because we already have alkalosis. No, we want lower bases to raise the pH level. Okay? Um, that is also true for metabolic diseases. One more note I would like you guys all to remember, if it's anything, diarrhea or vomiting, then it's metabolic for sure. Okay, so again, anything that's vomiting or diarrhea, it's related to metabolic diseases or like disturbances. If it's hyperventilation, hollow breathing, you know, it's a cause of respiratory. And you guys can connect the points, you know, because like if it was vomiting, we're losing stomach acid. So that means we're having alkalosis because we have less acids. If we have Diarrhea, there is so much bicarbonates that we are losing with the discharge. Because you have to know that there are so much bicarbonates in our stools as humans. So if we have diarrhea, we're losing so much bicarbonates, and that means we have metabolic acidosis. تمام. I hope that's clear. Okay, let's go for the second question. That was a very long talk, but if you actually focus, you'll get every type of question like this right, because kind of this is all the presentations that they can give you, all of the angles. Okay, so I want you guys to help me on this one. Uh, there are two patients that presented to the emergency department. Okay. The patient A has lightheadedness after a panic attack. Okay. And the pH level of his blood was 7.5. Um, CO2 was 30. And the bicarbonates were 24. But patient B had severe diarrhea for several hours. And this is a compound question. Focus. So, which of the following best describes patient A's disorder? And what is the expected arterial CO2 tension in patient B? You guys can take your time on this. Any other guesses or answers? Okay, perfect. You guys are all on track. Perfect. Perfect. It is indeed C. We inferred that patient A had uncompensated respiratory alkalosis, and patient B, we expected them to have 30 pressure of CO2. Let's dissect it here. For patient A, we had hyperventilation. Okay, and that means that we have less carbon dioxide, and therefore we have respiratory alkalosis. Why is it uncompensated? Because the bicarbonates here were normal, very normal, 24. Okay, so that means it's uncompensated. Decreased CO2, increased pH. According to Rome, that's true. Yani respiratory, because they're opposite, decreased CO2, increased pH, they're opposite. That means it's a respiratory issue. Okay? And because it's high pH, it's alkalosis. Well done, guys. Perfect. Okay, why is patient B 32 millimeters? Okay, because as we said, of carbon dioxide, sorry. Because as we said, patient B had diarrhea. And when you have diarrhea, you lose a lot of bicarbonates in your stool. And so, therefore, we have metabolic acidosis. And so, how do we compensate for that? We decrease CO2. Perfect. Thank you. Um, and so therefore, this is how we saw we know that the PaCO2 normally is 40 millimeters of mercury, and all of them are more than 40. And it doesn't make sense because we need a decreased CO2 value. Okay, well done, guys. I'm pretty happy that you are all catching up here. Okay, so one more question. We have a 65-year-old man that had a heart attack and experienced cardiopulmonary arrest when he was being transported to the emergency room. We have these laboratory results. Let's read them together. We have a plasma pH of 7.12. We have a plasma CO2 of 60. And finally, a plasma bicarbonate of 19. What is the following disorder? What do we think here? Perfect, perfect, perfect. Wow, wow. I'm pretty impressed. It is combined metabolic and respiratory acidosis. Again, for anybody asking me why, we see there is a decreased pH. So it's definitely acidosis. It's not D, definitely, for sure. Okay. We know that PCO2 is increased. According to Rome, this is true. CO2 is increased, plasma pH is decreased, and so therefore it's respiratory. That is established. Sorry. When we go to the bicarbonates, we go and see that they were also decreased. And when we go to Rome, we see the pH decreased and the bicarbonates decreased in the same direction. That is also true. It's a metabolic disturbance. And therefore, we were to infer that it's a compound disturbance. It's combined metabolic and respiratory acidosis. Perfect. Well done, guys. So the last question in this criteria, or this genre, is this. We have a 56-year-old woman, and the laboratory test results that the sodium is 140, chloride is 100, bicarbonate are 15. What is her anion gap and what type of acidosis is present? Wow, well done. It is A. The anion gap is 25 and it is metabolic acidosis. Briefly, to discuss this, the anion gap is the difference between sodium, chloride, and bicarbonate. So the formula here is sodium minus chloride plus bicarbonates. Okay, and this makes sense because we want to see the cations versus the anions, and that is what we call by the anion gap. Okay, this is the anion gap, that the difference between the sum of the anions and the cations. Okay, meaning that we have an anion gap that we don't know the source of. There's an anion making this equilibrium because we always assume that in the human body we have equal values of them. And the normal values of anion gaps is usually 8 to 16 only. So if we have an increased one, we definitely assume that the bicarbonates have decreased. And we can see on this figure, if the bicarbonates decrease, for example here, the anion would be greater as this much, and that would be over our normal value. It's just like a visual representation of what actually happens. Okay, so if we have a decreased bicarbonate count or amount in our body, we have a high anion gap. And therefore, we know that the decreased bicarbonate amount leads to metabolic acidosis. Again, metabolic is because it's related to bicarbonate. Acidosis because we have decreased bicarbonate, meaning there's going to be decreased pH. Okay? And we know that exactly how, because HCO is also decreased, you know? Like that's evident. That's literally in front of our eyes. Perfect, guys. Well done. I'm very much happy with our performance here. Okay, so for our last genre we have is micturition physiology. This is the last physiology lecture. It tends to have a couple of repeated questions. That's what I've seen. Usually, it's a very easy lecture. It's not something to be scared of. Okay. Um, with Dr. Abdul Ahad, I think he usually uses the same question banks every year. But the first repeated question we have was the first conscious urge to void is usually felt when the urinary bladder contains approximately 50, 150, 300, 500. Oh, wow. You guys have done your reviews already. It is indeed B. It's 150 milliliters. It's important to note also that um, you start feeling like your bladder is full at 400 milliliters of occupancy. Okay, it's important to like know at which amount of urine do you feel what sensation, match them together because they're mentioned in the lecture, and I think he can be like he can play within this question, you know. Okay, next up we have which of the following structures is the primary muscle responsible for micturition contains also mechanoreceptors that initiate the micturition reflex. What do you guys think? Is it the internal sphincter, external, detrusor muscle, or the trigony? Any other answers? Perfect, well done. It is indeed the detrusor muscle. It is controlled by the autonomic nervous system. It also has the mechanoreceptors that tell us or give us the sensation of if we're full, if we have the urge. It also initiates the micturition reflex. Now I have a like an off-topic question here for you guys. If the micturition reflex is automatic, okay, and the minute we get we start feeling the urge to go and void, um, the reflex has already initiated. What prevents it from already like from actually happening, you know? Um, what is this thing that tells us no, it's not time to void or it's not appropriate right now or controls it because the micturition reflex has already begun. Exactly. That is true. Both of the answers are true. It's a Ponentine maturation center and external urethral sphincter. But maybe it was an issue with me phrasing that question. It is the external urethral sphincter that constricts and closes and opens as we wish because it's under voluntary control. And that's why when it's we control when we can void and when we can't. Even though the micturition reflex is already there, it's happening, you know. But maybe you're not voiding. Why? Because of the external urethral sphincter is closed. Okay, we have a 42-year-old man that presented with urinary symptoms with an pelvic injury. Okay, he reported that he no longer feels bladder fullness at his as his like bladder fills, but when he was instructed to, he was able to contract the external urethral sphincter and delay urination. Okay. So after neurological examinations, we revealed that there is selective damage to neural pathways involved in bladder control. Our question here is the loss of bladder fullness sensation in this patient is most likely due to damage in which structure? Exactly. We're saying loss of sensation. Perfect. Really well done. It is the dorsal root ganglia of S2, S4 nerves. Okay, second question for the same case. So there is the patient has preserved the ability to voluntarily contract the external erythrosphincter, and that indicates that which of the nerves is still working. Pudendal nerve. Exactly. You guys are so right. Okay. So again, sensation is controlled by the dorsal root ganglia of S2, S4. And when the function is lost, we can't know when we're full and when we have the urge to void. But the pudendal nerve is what controls the external urethrosphincter. Um, and that means that enables us to control when we want to void or when we don't want to void. Okay, this is a small image I found helpful in summarizing the innervation of the bladder and the sphincters. I hope it helps. You guys can take a screenshot. We'll give you the slides anyways. Um, it was really nice, and this concludes our session today. It was really nice having this interactive session with you. Very beautiful, very well studied people you are, guys. It's very obvious that you guys have done your lectures and reviews before you came into this session. That's perfect. You guys are on the right track. I wish everyone here. Um, the best of luck. Okay, I wish you guys all the best of luck, and hopefully we'll hear the good news after your final. Have a nice rest of your day, and if you have any questions, do not hesitate to contact me or my co-host Hajar. Our numbers are on the slides that we just shared with you. Okay, have a good day, everyone.